So what is telehealth? We've got audio, video visits only. We have audio visits only. There's something called asynchronous, and then we have remote patient monitoring. And these have actually been around for quite some time. It wasn't introduced with the pandemic, but what we find is that most of the physician offices, especially, were not using these methods of care provision. So where you saw telehealth used mostly was in rural health clinics and home health agencies, potentially some hospice agencies, and really more on that front. So what we had with the pandemic is that all of a sudden we had to use telehealth because we had to keep our patients safe. So the methods which we are seeing that carried out mostly in practices and just across the healthcare continuum is audio video visits first and foremost. And if that isn't possible for some reason, maybe it's technology, or perhaps it's the equipment that the patient has, then we drop down into audio only visits. The store and forward is, again, something that's always been available since over the last several years anyway, and refers to the ability to communicate with your physician via a portal or some type of secure transmission mechanism where you're able to forward information. You could think about blood sugar logs, blood pressure logs, and then the physician would get back to you and give you some type of clinical direction in how to proceed. So that's what we think about when we're looking at asynchronous visit. And then remote patient monitoring is fairly new, but it has been around for the last couple of years. And it allows for providers to monitor chronically ill patients on an ongoing basis and get reimbursed for that. There are some other programs in addition to remote patient monitoring that are similar. They're just not provided through telehealth. All right, so what are the major differences now since the pandemic versus before with telehealth? Primarily, the explosion has been occurring because of the need to keep patients safe. And the way that we keep patients safe is to keep them at home as much as possible, especially the elderly population. So with that, we saw a lot of changes that had to take place, especially with Medicare, because that is obviously the payer for the elderly population. And the big sticking point with Medicare was the originating site for the visit. So before the pandemic, the originating site had to be some type of rural health clinic or some type of healthcare facility. It could even be a doctor's office, but the patient's home was not included in the definition of an originating site. So if the patient was at home prior to the pandemic and needed telehealth services, Medicare would not have reimbursed for that. They saw very quickly when the COVID-19 cases started escalating that they needed to change that originating site so that patients could get the care that they needed at home versus putting them at increased risk by coming into the doctor's office. In addition to that, it was also clear very quickly that Medicare and other payers needed to expand covered services in order to keep patients at home. And in doing that, they had to expand to new patients. They had to expand, like I said, to the originating site being at home. They had to expand to things like transitional care management and physical therapy and other types of services that traditionally would not be covered under the telehealth umbrella if it were not for this pandemic. And as I mentioned, for patient types, both new patients and existing patients are covered through this pandemic, primarily because they've chosen, and this is literally how they printed it, to overlook the type of patient when they're doing any types of audit during this time period. The type of patient, whether it's an existing or a new patient, just doesn't matter. It won't be on
Hmm.
their audit checklist, so to speak. So,
I
that's
didn't.
how that wording came about versus the clearer wording of the Medicare originating site.
That makes sense. So what can we use this telehealth for? There's a wide range here, huh?
Absolutely. There's definitely a wide range. And in fact, I challenge people to kind of expand their brains as it comes to telehealth because there's so much that you can do. And we inherently tend to restrict ourselves in what we think that we can do through telehealth because we're not used to talking to people over the phone and doing video and trying to treat something through that venue. And so it is a challenge anytime we introduce change. It's a challenge in how we think about things. And so we really have to expand our scope. But things like simple acute visits, sore throats, upper respiratory infections that are not related to COVID-19, and you can clearly
Mm-hmm.
tell that. That one's kind of hard at this point, so not a great example. Urinary tract infections for patients that have had those in the past and are familiar with their symptoms, simple rashes or lesions. So those types of visits could be done through telehealth visits. Behavioral health visits, counseling sessions can be done through telehealth. Medication management, both for behavioral health as well as chronic care medication management. Transitional care management, which typically would not be covered as a telehealth service, is now covered as a telehealth service. So if you have a patient that is discharged from a facility and you need to do that follow-up within the 7 to 14 days, that transitional care management is covered. The annual wellness visits, so checking on your Medicare patients at least once every 12 months to make sure that they're in check with all their preventive health services and they don't have an increased fall risk and they're safe at home. That is covered through
How do you,
telehealth.
so
Um,
just
uh-huh.
backing up here on all of these, just the regular visits, so you're relying a lot on your patient to explain how they feel, what they look like? Are you actually asking them to have someone look down their throat? I mean, you can't see the normal signs. You can't take their blood pressure. You can't. How are they? How, how do you talk them through that kind of thing?
So it does depend on your implementation. There are devices that can connect to telehealth platforms, so blood pressure cuffs and glucometers and even scales and dentists when they are doing telehealth, they will use instruments attached to the telehealth module. So there are, you run the spectrum of those. In your more simplistic format, you've got the patient who has their phone camera essentially, and so you're
Mm-hmm.
relying on that. And depending on who's there with them, your questions would be geared towards that end. You'd be surprised how the clarity is with looking at things like rashes and lesions and things like that,
Mm-hmm.
through telehealth. But it just depends on what the problem is and what you have available to you.
Right. Yeah, it's a whole new world.
Sure, absolutely. I did want to comment about, well, physical and occupational therapy. They were kind of a late add. Um,
Mm-hmm.
and so, if you need to do physical therapy exercise plans with your patients, then those are covered now under the pandemic codes. And the end-stage renal disease, the reason that one is in blue is that's kind of an exception to the rule because that was actually covered prior to the pandemic. They had increased the coverage of the end-stage renal disease visits with the pandemic, but once the pandemic is over, some aspect of end-stage renal disease will be covered. For example, you have to start out doing face-to-face visits, and then once you get past the first 3-month period, 2 out of every 3 visits can be through telehealth. So, that's just a difference between prior to the pandemic and after the pandemic.
Huh. Okay. All right. So how do we begin providing telehealth services? You're ready to do it. What's your first step?
Sure. So this has been one of the challenges with the explosion of telehealth. Just kind of wanted to jump in with both feet and not really thinking through the process. So, with telehealth services, you do have to think about the fact that it is a new business model for you as a practice. So, certainly there's staffing, there's equipment, there's workflows that need to be implemented, there's policies and processes. So you can't totally skip over that, though. Definitely there was a need for a quick ramp up for telehealth services.
Right.
Do need to design that business plan and identify, the things that you're going to use to implement. You do need to choose a vendor, and in doing that, you need to think about your practice and the things that you need. For example, I mentioned that there are telehealth venues that you can use devices with versus those that are more simplistic, where you just have what you need for telehealth, and then you're going to use your EHR to supplement all of your documentation. You want to make sure you define and train your workflow, because it is different. There's certainly things that we're going to talk about that are required for telehealth, and you don't want to forget to market it to your patients, because one of the things that we've seen, especially with physician offices, is once this pandemic occurred and there was a stay-at-home order, the waiting room was then empty. And so now, my revenue has gone out the door, and I need to quickly figure out how I'm going to fix that. And so one of the ways, obviously, is through telehealth, but making sure that you market that availability to your patients so that they know that you are now offering telehealth and the things that they're able to contact you for to receive telehealth services. And then obviously you want to provide and bill for those services. Billing is key. And we'll talk a little bit more about that in a few minutes.
So once you pick a vendor, so you can't just jump on a Zoom call and you just say, hey, jump on a Zoom call. You need to have a plan in place and then let them know all of the processes. So send out an email to all of your patients saying, this is what you do, this is how you do it, this is how we're handling it, and this is why. Yeah.
So you can jump on a Zoom call, and a lot of our practices and just providers in general did that initially, but you do need to follow around to get the most out of your telehealth program. You need to follow back around and kind of check off these other boxes for implementing a new business line, if that makes sense.
There is a Zoom Health arm to Zoom at this point, right?
Oh, absolutely.
Yeah.
Absolutely. And we'll talk a little bit about vendors in a minute here.
Great.
Oh, look at this.
Look at that. What vendors can I use? Zoom right there.
Yeah. All right. So one of the things that that came out in the changes with the pandemic and telehealth was, you could use non-HIPAA compliant venues for provision of telehealth services. So FaceTime, Skype, whatever you needed in order to just stay in touch with your patients. And, that was great initially, like I said, but we always, as healthcare providers, want to go back to making sure that we're HIPAA compliant, especially since we know that telehealth was here before the pandemic. And now, since we're all doing it, telehealth is more than likely going to be here after the pandemic, because people just love it. So with HIPAA compliant versions, I've just listed a few here, and they're in no particular order. Doxy.me is a venue that is HIPAA compliant. Zoom does have a telehealth arm that is HIPAA compliant as well. Both of those will issue business associate agreements to your practice with your paid licenses for those venues. So it's important to check out more than one to see which one is going to work best for you. But these two are both very easy to use, and they're not browser based. So patients don't have to have an account. It's not like having It's not like having to have an additional portal account, if you will. It's
Mhm.
very easy. You send them a link, they click the link, and they're basically in the meeting. And with the settings, you can make it really easy for the patients when they join for like their video to already be on and their audio to already be on, so that they don't have to loop through those challenges. They
Nice.
are both very secure venues. The browser-based versions, and there's some good browser-based versions as well. It's just an extra step for the patient because they do have to create an account and they do have to have access to either the browser on their phone or laptop, something like that. And
Right.
though the non-HIPAA compliant options are still acceptable at this point, that would not be my first choice. It was great to get by, but now we need to use one of the HIPAA compliant ones out there because there's so many of them to choose from. These are the very simplistic ones. So if you're looking at things like devices being attached, you're going to look towards things like MedPod or something that is more sophisticated and can allow for those devices.
Like teledoc. So do you recommend having many of these available to your patient? I mean, what if, you've got an elderly patient and he has learned FaceTime or Zoom, but doesn't necessarily have the capacity to get on doxy.me that you've already set up. Do you set up several?
Most practices do stick with one, and Zoom and Doxy.me are very similar from a patient implementation perspective in that it's very easy to just hop on a call just like it is with Zoom or FaceTime, right?
Hmm.
It's basically the same process. And that's one of the reasons why I listed them, not because they're the only ones out there, just because those are the ones that I have the most experience with in
Hmm.
implementing with my clients.
Just thinking of my father-in-law who would not be able to do much of this, which, there's a lot of clients out there that are not going to be able to Zoom
Yeah.
easily.
And one of the things that is helpful as well, if you send out marketing, is to also send out instructions.
Hmm.
Um, we did a lot of that with marketing and sending out those screenshots of what the app looked like and how you would get to it and what things would look like when you logged in. And the providers are really good about helping lead the patients through also, because they do understand that there are initial challenges. But typically after they get past that first interaction, then they really like it and they're really good at it. You'd be surprised.
Yeah, they can learn when they need to. All right. So are there HIPAA concerns with telehealth? Obviously.
So generally, yes. There was that notification of enforcement discretion, which basically means, again, that um, HIPAA audits would overlook whether or not you were using a HIPAA compliant option to provide your telehealth services during this time period. But again, because there's so many out there that are HIPAA compliant, there is one for everybody to use. I'm quite confident. So I think we can go the HIPAA route now that we're kind of past that initial, oh my goodness, what are we going to do? I have a patient to see now and I don't have a telehealth option yet. Let me jump on a FaceTime call.
Right. So there's a lot of leniency there right now. Is there any worries about the future? So, people listening in or anything like that on the side? Do you have to worry about that, or is it just all bets are off?
So with the telehealth visit, when you start it, there is kind of some housekeeping that's needed as far as, are you in a private environment? Are you comfortable with anyone else that might be in the room with you? Just kind of making sure that you're covered from that perspective. And the exception is only going to last as long as the public health emergency is in action. So
Yeah.
when that is ended, then we would go back to needing to be using a HIPAA compliant. and no one wants to go through implementation twice, right?
Right. So it might be good to keep that in mind now. Okay, so important. How do we get reimbursed for telehealth services?
Super important question. And there has been so many changes with this over the last month. It's just been crazy. There was one point when they were publishing something new like every day that was different. And so that's kind of relaxed for right now. And this Medicare billing code, so in the deck, that actually links to the list of codes. There are, gosh, over 100 codes. Some of them were added for the actual pandemic. And so those are indicated on the spreadsheet that is associated with that link. And what you're going to do is put your billing code on your claim like you normally would. And for Medicare, they originally said that you would need to bill this with a place of service 02, which makes your reimbursement be at the facility level, meaning that it's a little bit lower than it would have been had you billed the place of service 11, which is your office, where you would get the non-facility rate. So since then, so originally it was place of service 02, and now it's place of service 11 with modifier 95, which indicates that it is a virtual visit. And that would get you the non-facility reimbursement for your telehealth visit. Now, if you use the place of service 02, your claim is not going to get rejected. It's just going to get paid at that little bit lower rate than it would be if you had billed the place of service 11. Now, with private insurance reimbursement, it is the place of service 02. Some of them do have modifiers, so it's really important to look at your payers and what their requirements are for billing telehealth visits. Some of them use modifier 95, some of them use the G modifiers, some of them don't require any modifiers, so you really do need to look. And then Medicaid, their reimbursement varies by state, both prior to the pandemic and then afterwards as well. So, you know, you would need to look at the waiver for your state to see what the Medicaid coverage is for telehealth during the pandemic.
So does it matter where the provider is when the telehealth visit occurs, office or home?
Sure. So that's a great question too. And there's been a lot of discussion about this question. So the office is normally the place of service, right? And then what we found with the pandemic was that there were a lot of providers working at home, and then nobody knew what address to put on the claim. And so they did come out with instructions on this, such that it doesn't matter where the provider is, whether the provider's in the office or whether the provider's at home. It's where that provider typically provides services from. So the only time that you would ever use a home address or anything like that is if 100% of the time, and that was the purpose that you had hired that provider, was to provide telehealth services 100% of the time from their home. And then that would be their office. But other than that, and certainly during this time period where so many people are working from home, the office is where the all telehealth visits are occurring from. Does that make sense?
Yeah. Yep. Are there special visit requirements for telehealth?
Yes, there are. So you do have to get verbal consent from the patient. There are insurances. So your malpractice insurance may require that you get written consent. So that is something that you need to check in with, is your malpractice insurance, to make sure that they don't have any additional requirements for telehealth services. But beyond the malpractice insurance, verbal consent is all that's necessary. So you get the patient's consent, you document that somewhere in the medical record that you obtained verbal consent, and then you also educate them of their financial responsibility. And this does vary by payer, and it varies by reason. So for the most part right now, if the telehealth visit is for COVID-19 symptoms or to evaluate someone for COVID-19, then the copays are waived. However, if it's for some other purpose, then the copay would persist. And if you're Medicare, the provider has the option of waiving that copay during this time. So, it is important, again, to make sure that you're up on your payers to see, what the patient's financial responsibility is going to be, and, also what the variations are related to that. But there is typically some type of responsibility for the patient for a telehealth visit.
So I think, a deck like we're providing to our listeners today, it might be a good idea to print it out, and you go down through these things, and say you get to this verbal consent bullet point, you might want to, write in or written consent ? Go check that, give yourself that information, and write your script to begin each of your consultations from this, so you have everything in line. I think this is a really good format. There's just so many things that you need to check as you go along here. I would recommend doing something like that, because you've already listed 6 things they need to know.
Yeah, absolutely. And in a lot of EHRs, you're able to create templates or some type of customization that can help you out with with walking you through, so everybody makes sure that they at least get consent, which is the primary thing, and then that they also touch on the others, and that there's consistency. And that kind of goes back to the business plan and making sure that you've developed your workflow and your processes, and you've educated your staff on how to approach this with patients. Because a lot of times, what happens with scheduling is patients call in to cancel their visits because they don't want to go and sit in the waiting room. And you also need to, make sure that your front staff, your scheduling staff, are comfortable having a discussion with them about transitioning their visit from a face-to-face visit to a telehealth visit. Because that's something that, it's easy when you call into the office. And I know this is a little bit off topic from this, but it kind of goes into having that telehealth visit and making sure that you understand your talking script for that.
Right.
Because a lot of times, if the front office staff and the scheduling staff aren't well versed in what telehealth is and how to encourage patients and help make them feel comfortable with a telehealth visit, then that patient's just going to wait. They're just not going to get seen. And that's really not okay for our chronic care patients. And, even sometimes patients that have an acute need that normally they would come into the office for, but now maybe they're afraid to come into the office. It takes a lot of encouragement, because it's a huge change for them as well.
Right. Yeah, maybe just a script for everyone for every applicable question would be helpful.
Right.
Yeah, great.
Right.
Okay, so what happens with telehealth when the public health emergency ends?
Absolutely. So it is definitely going to persist. And, what we're going to realize, and a lot of providers have already realized through this process, is it's really a valuable augmentation to care, especially with chronically ill patients, and some even acute visits, or especially like medication management. You can think of a lot of reasons just personally when you went to the doctor's office for your medication renewal, or for a follow-up to an acute problem that you had, and you really wanted to cancel that visit, and maybe you did even cancel that visit, but if you could have done it through telehealth, then you would have kept your visit. So, what we see with telehealth is increased compliance as people get used to using it as a venue for for providing healthcare. And, like I said, before the pandemic, there were very, very few providers that were providing telehealth services. And it wasn't because it wasn't available, because there were private payers that were reimbursing for it. So, I'm not sure whether it was a lack of knowledge or maybe not being comfortable with implementation of, this into your business model. Maybe it wasn't a good time. I don't really know, but I think what we'll learn from the pandemic is that there's definitely a place for telehealth among the other venues that we use for providing medicine.
Right. I mean, I think it's similar to the EMR onset. My doctor still had files for days, just, right when it needed to go fully EMR. They're just stuck in their ways.
Right. They don't like change,
Okay.
especially if it's a big change. I mean, going from a face-to-face visit to a telehealth visit is a huge change. You can't touch your patient. You can't, you just have that video piece, and you have to give directions to the patient, not only to help out with their technology, but also to make sure that you're collecting the information that you need that they're comfortable in the visit. So, lots of different things come into play there, which is a learning curve both for the providers as well as for the
Yeah.
patient.
Well, and it's scary too. There's a lot of compliancy issues here that, they're used to this being all wrong. So,
Sure, absolutely, absolutely. And then, with Medicare, they've had to relax their reins quite a bit for telehealth services. And it's interesting that the originating site was not home in the past, but for some reason in the last couple of years, they just have not changed that originating site in their legislation. And I'm hopeful that what we'll see next year is that, at least for some codes, Medicare will cover telehealth services. Can I predict that with certainty? No, I can't. But I do think that what Medicare is going to see is that the cost of care can be assisted and decreased by using telehealth services to provide some of the care needed by the Medicare population.
especially
And then,
just medicine. I mean, just getting your medicine should be an easy add-on to this,
right,
versus things where you have to touch and feel.
exactly. And then, of course, private payers will obviously continue their coverage of telehealth services. They were seeing first, because they were covering it first, how telehealth services can really cut costs in taking better care of their patients, because the better the preventive care is on the front end, typically the lower the cost of care is for problem visits and interventions on the back end. So there's definitely a shift in where you end up paying for care, whether it's on the front end with a lot more preventive services through telehealth, or whether you get stuck with that on the back end. So it's definitely here to stay, and that's why I think it's really important when you're implementing your business plan and you're thinking through how you're going to do this, that you address it as something that's here to stay, and not a temporary, here's a quick fix for right now.
Yeah.
Because that's definitely not the case. It will certainly be here for a longer period of time. And I wanted to go back here just a minute, and I really encourage you to look at these Medicare billing codes, because I think that you'll be surprised at the number of things that can be provided through telehealth services. We talked about new patients office visits. We talked about existing patient office visits, physical therapy, occupational therapy, nutritional therapy services can be provided through telehealth, transitional care management, the annual wellness visit. So, lots and lots of things that we do for for preventive care and to keep their care going during this pandemic are covered through the telehealth services.
Great.
So we do have some questions here. Do you want to kind of start going through those, and then we'll talk some more if we have extra time?
Sure. So one of our first questions was, can you provide an update on the CMS update that providers can bill based on time using total cumulative time on the DOS versus 50% of the time being face-to-face, as well as the specifics behind using MDM to govern your level of service when using the 2021 history and exam philosophy? It's from Michael Burnett.
Yeah, and I'm reading it too. So
yeah.
Yes, so providers can definitely bill based on time, and each one of the office visit codes, so your 99203, 4 and 5, 99213, 4 and 5, has an associated time with it. So I can't quote you those times off the top of my head, but I can certainly put that in the published frequently asked questions. And with the medical decision making to determine your level of service, in the 2021, and I believe that you're referring to the fact that they don't have to count bullet points anymore for history and exam. And you can correct me if I'm wrong, Michael, but I believe that's what you're referring to, that they don't have to count the bullet points for history and exam any longer. They can use more of the time-based element. And that certainly comes into play when you're doing telehealth, because that's really all you have is time. You're not putting your hands on the patient. So there are some things that you can observe. You can certainly observe how they're interacting with you, their mood, their affect, whether or not they're oriented. You could even watch their gait. If, whether you're a physical therapist or not, you can watch their gait. So there are some things that you can observe and document for physical exam, but you can also base your visit on time. And in some EHRs, they help you do this, where you put in 100% of your time, and then it takes the 50% for you and gives you the billing level that's appropriate for that amount of time. But if you don't have that as part of your EHR, then you can just use the guidelines, the time guidelines that are published with the codes to help you in choosing the right one.
Great. So Bethany Wilson had a few questions. Can you talk about what documentation is needed to support annual wellness visits to support recapture of conditions?
Sure. So with the annual wellness visit, you still have to collect all the survey type information. So you would still follow the checklist with like the fall risk assessment and the functional assessment that you're going to do. You would still go through that process with the patient, and you would document that in the EHR. So, whether the patient's filling that out ahead of the visit and then submitting that information to you, or whether you're doing it during the visit, either way is acceptable during your telehealth visit for the annual wellness visit.
Okay, and we do have a couple questions here about the second question from Bethany. Is it only video and audio that is applicable to annual wellness visits?
Yes. So annual wellness visits would, in order for you to get a full reimbursement, would have to be audio video. When a visit is not audio video, then it actually goes to a different code. So audio visits only, and I can include those in my my answers as well. But
Okay.
if you're doing an audio visit only code for Medicare, it is the telephone visit, and those are like the 99442, 443, and 444. And it depends on the amount of time that you actually spend on the phone with the patient, and that is a covered service. And then there's also, of course, the billing codes for um, for the asynchronous, the store and forward, that can be billed as well if you end up going that route. And the reimbursement for those is significantly lower. It tends to be $25 or less for asynchronous. The phone visits, depending on time, and there's 3 different levels, are, may range from like $20 up to $75 if you use the full amount of time. And some of that's impacted by geographic region as well, as you're used to with your CPT codes and your reimbursement. So.
Okay, well, this is from Shauna Metters. What was Medicare's rationale for originating site prior to COVID to have PT be in a medical facility? Does that not defeat the purpose of telehealth?
So their original intent for telehealth was that it would be used for consultative services from rural health clinics or healthcare provider shortage areas, so that they would be able to have access to other providers if needed. So it really was more of an extension of the healthcare provider's role versus actually extending care to the patient. I'm not sure whether that makes sense or not, but it was, you were contacting through telehealth another provider to supplement the care that you were providing. So let's say you're in a rural health hospital and you have a patient that comes in with head trauma and you need to consult with a neurologist that's in the closest metro area to provide care for that patient. Or you have a patient that's having an acute psychotic event and you need to consult with a psychiatrist in order to help treat that patient. And that was how Medicare was approaching telehealth services. Now they did start to introduce other programs so that they could make telehealth available in a wider network, so to speak. So the end-stage renal disease program, where the patient that's getting in-home dialysis has the first few visits face-to-face, and then they're able to do 2 telehealth visits and 1 face-to-face visit. So that was one of the programs that they introduced in the beginning of 2019 related to telehealth services. And then the other one was with remote patient monitoring. So that's another program that they were, introducing to help get telehealth into the provider market. And they simply just have to change regulations in order to make that originating site encompass the home as well as, other healthcare facilities as well.
So if you have a patient that comes on and you would normally send him to another provider for something, whether it's a dermatologist, say they have a mole that they want to get looked at. So instead, so this all can be done inside of telehealth. You then send them over to that, and then hopefully they have a similar telehealth provider situation going on there. I can see it getting confusing as you start to move your patients from provider to provider. It's they get used to your provider situation, and then they go over and they've got another telehealth program to handle there. Is there do you just try to limit that right now, or are you just...
So previously, and with this originating site, let me answer it again because I may have been confusing. So if we talk about pre-COVID-19, the originating site had to be a facility or rural health clinic. All right, so you're talking about the patient actually being in front of someone during a face-to-face visit, and you're calling out to get telehealth services from another provider.
Right.
Okay, and then post-COVID-19, you would have the originating site can be the home for Medicare services. So you would just have your visit with the patient, and then if they needed a referral, you would refer them. practices that are multi-specialty, they can, have the other person come in the room, like if they have behavioral health, integrated behavioral health or something like that. But if it's a case of, I'm doing a telehealth visit with you, and then I need the doctor down the street to do a telehealth visit, then it's a separate interaction. Does that make sense?
Yeah, yeah. So there's two ways you can go about it. If it's inside of your network, you can even have them just jump on, but yeah,
Right.
very cool. I mean, I can't see this going away. It's just, it makes everything easier once you have it. It's almost like, okay, there's a fire now, you've got to get this up and running, but eventually it's going to be great. Right?
Sure. I mean, it definitely makes things easier. And, if you just think about it, even not just Medicare, but for the working population, when we're at work and we need to do that follow-up visit, or we need to run to the doctor for something, it takes forever. You have to get up from your desk, you have to go to the parking deck and drive to the doctor's office, and you have to wait. I mean, it can easily take up a good 2 hours of your day. Whereas if you could just do a telehealth visit, it might be 15 minutes.
Right. It
So,
gets rid of that sitting in the room with the slip on. That's great. That's my least
right.
favorite part.
And the magazine and all that stuff. So
waiting in the second location. Yeah, no, this is awesome.
Absolutely. So do you have any more questions that you're seeing right now?
I don't have any more questions for you. I'd just like to thank you so much.
Hang on. I was just going to talk a little bit more about the audio video, the audio only, and the asynchronous visits, if that's okay.
Oh yeah, excellent. Yep, go ahead.
All right, so I'm going to go back here just to this slide really quick. So with our audio video visits, those are the visits where we're looking at those Medicare billing codes, and we're primarily billing services just as if they were face-to-face visits, and we're getting reimbursed as if the patient was in front of us, okay? The audio only visits, there are some insurance companies that will reimburse audio only visits as the same rate as a face-to-face visit. Those are not very widespread, but there are some. So again, really important to check your payers. Medicare for audio only visits will only pay you for the phone visit. And they actually used to not reimburse this at all. So they've expanded into using that 99442, 443, 444 code for the audio only visit, so providers would get paid, because they did recognize the fact that with the Medicare population, some of the patients just cannot do video. They either, maybe they still have a flip phone, or, maybe they're just not able to navigate their technology and they don't have anyone who can help them out. So we do have the audio only visits. And then for asynchronous, we are looking at the 99242 and 243. I believe those are the codes. And like I said, I'll put them in there. But that reimbursement, those are meant to be like interactions through a portal where they're exchanging information. Like I said, maybe they're sending you a document you need to review, or maybe they're sending you a portal message describing symptoms. Some of the portals actually have forms that can be filled out by the patient, and then the doctor responds with information, and that is a type of asynchronous visit. Those visits are not reimbursed very well, and so if you can do your audio video visits, that's where you're going to get the most of your reimbursement. So anyway, and I'll put information about those codes when I answer the questions also. There's also a quick check-in type visit that Medicare talks about. It's called a virtual check-in, and that one is literally intended to just be a super quick, do they need to pursue care or not, or maybe they just have a really quick question. And that one is not reimbursed very well either. We're talking like $15 to $20. But it's better than zero if you're having to answer the question anyway. So I did just want to go back and, talk a little
Yeah.
bit more about those types of visits, since we had a little bit of extra time.